Okay, Nuhu, we're live.
Good morning, good afternoon, good evening, everyone. Welcome and thank you for joining us on this webinar today on engaging the private sector for quality of care for maternal, newborn, and child health. My name is Nuhu Yakub, and I'll be the facilitator for this session. We are also at the same time live on YouTube. Next slide, please. So it is the fourth in this series of webinars on engaging the private sector. It is hosted by the Network for Improving Quality for Maternal, Newborn, and Child Health, supported by WHO, MSD for Mothers, and the Child Health Task Force. The network is leading work in 11 countries in Africa and Asia to support efforts to accelerate the reduction of maternal, newborn, and child mortality. Included in this effort is to congregate the private sector to expand access to quality of care. Therefore, we focus on private sector delivery of quality health services with country examples of successful engagement mechanisms, and also to give private providers perspective on working to improve quality of care. So today, we will be going to Lagos State in Nigeria, a city with a population of close to 27 million people, and learning how the Lagos State government has partnered with Farm Access Foundation to implement a public-private partnership to expand access to quality health services for women and children. The webinar will be of two parts. In the first part, we'll hear from Dr. Ibironke Dada, the Director of Quality Farm Access Foundation in Nigeria, and she will be talking about the foundation's work partnering with the Lagos State government. Will be Dr. Abiola, the Executive Secretary for Lagos State Health Facility Monitoring and Accreditation Agency. She will give us background about the overall work that the agency does in terms of improving access to quality of care for mothers, newborn, and children in Lagos in both private and public health facilities. In the second part, after both speakers present, we really want to hear from you, and we will have a session where the speakers will respond to your questions. So please type your questions in the chat box during the webinar, all through the webinar. It's now my pleasure to welcome Dr. Dada. And please, over to you, Dr. Dada.
Thank you so much, Nu. Good afternoon, everyone. My name is Ibironke Dada. I work with Farm Access Foundation. I'll be talking about the strategies to improve access to quality MNCH services in Lagos State, Nigeria. And this is the outline of my presentation. It's basically around introducing my organization, Farm Access, talking about the challenges of the health sector, system strengthening support to Lagos State, in terms of scheme design and implementation, as well as smart solutions for quality MNH services in Lagos.
Sorry, Dr. Dada, we don't see your slides. Can you ensure you've shared them?
Okay, I'm disabled. I'm just realizing you need to transfer.
Yeah, you should have permission. Sorry about this. Go for it.
Yes. Sorry, everyone.
Not at all.
I'm sure everyone can see my slides now. Okay, so I'll be introducing Farm Access. I would also talk about the challenges of the health sector. And I'll also talk about the system strengthening support to Lagos State in terms of scheme design and implementation, as well as smart solutions for quality maternal and newborn health services.
Sorry, it seems your presentation is not in the presentation mode, it's showing the slide mode.
It's in the presentation mode from my end. It's in the presentation mode.
Yeah, if you just hit, there you go. Perfect. Thank you, Dr. Dada. Sorry about that.
Sorry. So Farm Access Foundation is an international non-governmental organization. And our focus is around working with state governments and national governments in realizing their UHC ambitions by supporting them to develop their health insurance schemes. We also try to facilitate loans for health SMEs in partnership with local banks, and that's through our medical credit fund. We also try to leverage on technological innovations to help make healthcare affordable and accessible to all. And whilst doing this, we look at the quality of services provided by the facilities through our Safe Care Quality Improvement methodology. But we also try to measure the impact of our work and try to build that proof of concept and advocate for scale up by working with the Amsterdam Institute of Global Health and Development, as well as local academic institutions, such as the Lagos State College of Medicine and the University of Ilorin Teaching Hospital. So what are the challenges? We have issues of market failure and funding gap. In terms of demand, we have a high poverty rates even in Lagos. And so there's an inability to pay for services out of pocket. We have a low trust in the health system, low insurance coverage, and social barriers hampering uptake, even when subsidized. In terms of supply, we have weak regulation. We have shortages in skilled staff, drugs, equipment, and issues in quality. And there's a lack of transparency of cost and availability of services. And we need to know that 60% of services are actually accessed from the private sector and payment is made out of pocket. And so who is affected? We have women, newborns, and children disproportionately affected. In terms of maternal and neonatal mortality rates, it's unacceptably high in most African countries, but it's especially poor in Nigeria. Women often visit clinics too late or not enough, causing unnecessary complications. We also have inadequate skilled health personnel and lack of health commodities in the clinics. So in terms of our maternal deaths, we have about 814 maternal deaths per 100,000 births and 39 neonatal deaths by 1,000 live births. So coming down to Lagos State in Nigeria, Lagos State is really unique. It's the economic nerve center of Nigeria. It's the most populous but smallest state in terms of landmass. So if you're looking at the map of Nigeria, you can see that little corner occupied by Lagos, but yet it houses the largest concentration of private health facilities in Nigeria. Greater than 90% of the over 4,000 health facilities in Lagos are private health facilities. In 2015, the Lagos State government enacted the Lagos State Scheme Law to mandate health insurance for all residents. And when we're talking about population, Lagos has over 27 million persons. So when it comes to interventions we have done with the Lagos State government around demand, we were a member of the core implementation committee of the Lagos State Ministry of Health that led the design of the Lagos State Health Scheme. In terms of scheme design and pre-launch, we supported the actuarial calculation of premiums for the Lagos State Health Scheme. We also helped to design the Lagos State Benefit Package, which is MNCH focused. We also supported the development of the provider payment mechanism, the medical coding price list, the scheme operational guidelines, the marketing and scheme rollout plan, as well as a 3-year financial model. In terms of scheme implementation, we supported a proof of concept on the Lashma ICT platform called Alimocare with 1,250 lives. We also keep supporting interventions around improving enrollment and retention through behavioral nudging. And we've also done a couple of tests around innovative financing, such as diaspora remittances. And we continue to support issues around marketing and outreaches, as well as data analytics and insights to optimize the scheme. So when I mentioned the MNCH focused benefit package, these are a list of services provided under the Lagos State Health Scheme. Vaginal delivery, hysterectomy, even in the case of postpartum hemorrhage, cesarean sections, and these are just a couple of the examples. But we know that for a sector that is largely private sector driven, regulation is really, really key. And so we supported the Lagos State Health Facility Monitoring and Accreditation Agency. The second presenter, Dr. Idowu, would be talking about how PharmAccess supported and other organizations have worked with the agency. But really, some of the work we did was around the mapping of private health facilities, a review of the regulatory framework, an organizational capacity assessment of the agency, and developing a capacity strengthening plan for the agency. We also supported the development of the pharma process manual, the basic standards for health facility registration, and helped to digitize the health facility inspection tool and the registration platform. So when it comes to issues around quality and assurance and improvement, for any scheme to survive, we want to be sure that people are getting good quality care, and that's the only way you can retain and get people to also purchase health insurance. So one of the things we tried to do was to look at issues around empanelment. So we wanted to facilitate that transparent empanelment of health providers by developing the LSHS accreditation and empanelment guidelines and supporting a pharma with a checklist to assess the capacity of 698 private health facilities to provide MNCH services. Only 179 of these facilities met the minimum quality requirements, of which 115 were private. We're also supporting the state with on having a state quality improvement program. Lagos State adopted the Safe Care Quality Improvement methodology for all empaneled health providers. And through this, we trained 20 state quality assessors and 45 quality facilitators to support health facilities. Private facilities can now join Safe Care Quality Improvement program at a discounted rate negotiated by government. So looking at the QA systems and the QI systems that we've been able to support, on the pharma side, they're responsible for quality assurance, and that's using the health facility inspection tool. On the LASHMA side, which is the Lagos State Health Management Agency that oversees the implementation of the insurance, we've been able to support them on issues around quality assurance and audits of private and public health facilities empaneled on the scheme. I've already talked about the quality improvement process, which is really centered around safe care. So looking at how we've been able to impact on MNCH services and family planning services in Lagos State, EFAMA as the regulator oversees the implementation of licensure processes, and that's really around facilities having basic equipment and materials, consumables, staffing, and of course, having the referral system in place to cater for the clients that they see. But when it comes to safe care, the quality improvement methodology, we're looking at a deeper, a wider scope of MNCH and family planning services. And it's really around the skills of the staff, the adequacy of the staff, the qualification of the staff, having a continuous training program or education program for staff. And then we're also looking at processes in terms of protocols, SOPs, guidelines, documentation, maintenance, audits, and health education provided within the facilities. So we basically are looking at triaging, fast tracking, and referrals, emergency care, resuscitation, antenatal care, labor, delivery, postnatal care, neonatal and pediatric care, family planning, how patients are assessed and followed up, and as well as infection prevention and control. So we believe all these together would help towards improving MNCH outcomes in Lagos State. And then we're very strong on benchmarking. We have a couple of improvement areas that we look at when we're working with hospitals. We look at issues around business management, customer care, and MNCH services circled in red right in the middle of the slide. And we also look at issues around HIV, infection prevention and control, just to mention a few. The next slide shows you a comparison between public facilities and private facilities. So on MNCH services, private facilities seem to adhere more to standards. For emergency care, private facilities are not performing as well, are better performing around emergency care, as well as infection prevention and control. For all the work we do, we realize that technology is really important because it can help you improve the efficiency of your processes, and it can also help you scale up your interventions. So in the last couple of months, we've been working with Lagos State Health Management Agency on a new project called Mom Care. And it's really around improving maternal child health outcomes through smart solutions. It's a 2-year project. And the objective of that project is really around addressing poor compliance with MNCH standards that we usually find at hospitals. So for us, our focus is to improve the quality of care, to improve access through establishing a digital platform that connects the private providers and the pregnant women. And we want to develop a business case for quality mother and child care by incentivizing a smart contract. And we also want to stimulate family enrollment on the Lagos State Health Scheme. So from the patient's perspective, how do we get better health outcomes? It comes from providers adhering to a quality journey based on WHO's standards and creating that enabling environment that transforms the culture of care and improves outcomes. And so it's really looking at the hardware in terms of protocols, medical and operational prerequisites. When we talk about protocols, the clinical care protocols, when we are talking about the medical and operational prerequisites, we're looking at quality elements such as the skilled staff, the equipment, processes, and drug supplies. And then we're looking at software, which is really around experience, promoting that positive experience and improving satisfaction throughout the maternal journey. And then we're looking at ways of nudging patients to utilize services and of course, protecting health facilities in terms of them getting their full payment for complete journeys or complete services. So it's really around incentivizing the patient and of course, the financial sustainability of the provider. So when we talk about a healthy journey, we tend to say we must have a minimum of 4 antenatal care visits and an additional antenatal care contacts through phone calls and through SMS messaging. And then we want the woman to have a good delivery right at the facility where she accessed all her antenatal care. And then we expect that the woman will complete 2 postnatal care visits as well as 3 visits for immunizations. So what are the supportive systems that we have for mom care? It's really targeting the patients and the providers. For the patients, we're looking at all pregnant women that come to the hospital, and we're also accepting of the fact that there's some women who would be vulnerable or who would not have the capacity to pay for services. And these are women that should be targeted with premium subsidies. So we also have a multi-method poverty assessment tool that can be used to ascertain if a pregnant woman is eligible for premium subsidies. We want to also nudge our patients and influencers with SMS and BCC, behavioral change interventions. We want to enroll women into the health insurance scheme. We want to monitor their patient journey schedule alerts, and incentivize care utilization. We also want to collect patient feedback and service confirmation through SMS and USSD. But on the provider side, we want to support them to improve the quality of care that they provide, not just for MNCH services, but for all services within the facility. So we'll only contract facilities that meet a minimum of safe care level 2. Mom care will also link new mothers to providers on the LSHS. We'll provide quality support to them to promote adherence to MNCH standards. And then we will set payments based on quality utilization and patient feedback. And LASHMA would manage the claims and schedule payments using their ICT platform. So this is the user journey in a nutshell. The patient visits the mom care provider. She receives care according to the LSHS benefit package. The facility imputes the information and computes the billing. Care analytics in the back end will do all the processing. And at the end of the day, we will be able to determine whether this woman has had a good quality journey or not. So in terms of journey tracking, we'll be looking at whether it's a good journey, so you get 5 stars. If it's not a so good journey, you can get anything from 3 to 1 star. So for instance, looking at the screen, you would see that late enrollment were a fine journey, meaning she attended antenatal care. She was delivered at a baby was delivered at the facility. There's 4 stars. But for a bad journey, meaning antenatal care was insufficient, the patient did not deliver at the facility, then you get much lower marks. So we found that the key drivers for a good journey is really around the mother's profile, availability and timely use of ultrasound, and of course the distance to the clinic. So with mom care, we're proposing a digital business model for quality MNCH, maternal and newborn care. And it's really around demand, whereby women are able to choose bundles of care covering the full journey. We have behavior nudging, and then there's quality support for providers. And of course, we continually research on the work that we're doing so we can improve on and develop new bundles. And really payment would be linked to quality, and then there'll be transparency on the quality and cost of care. Thank you very much. At this point, I'll be handing over to Dr. Idowu to continue with the second presentation.
Now newborn and child health services in Lagos and the strategies to improve MNCH indices in Africa's most populous city. Next slide, please. Dr. Dada, next slide, please. Hello, Dr. Dada.
Maybe we put it on from our end. Olive?
I don't have control of the slides anymore.
Olive?
Yes, let me just get it from our end then.
Thank you. Okay, so in the meantime, I'll just discuss around what I'm going to talk about. I'm going to briefly talk about who we are and what we do. I'm also going to compare our MNCH statistics with the national average. I'm going to talk about the challenges and the barriers that result in poor MNCH indices, and what the Lagos state government efforts are towards addressing these challenges, the role of a farmer in regulating quality MNCH services, and smart conclusion. Thank you.
Can you see the slides now?
Yes, I can. So can I have the next slide, please?
Absolutely.
Thank you. Okay, so I've talked about what I'm going to be presenting. Can I have the next slide, please? Thank you. Okay. Okay, so who we are. I already said we're a pharma health facility monitoring and accreditation agency. The agency was established by the Health Sector Reform Law 2006. That people are complaining they cannot see the slides.
I think the slides are visible now to everyone.
Okay, all right, thank you.
It's not visible any longer.
Okay. All right, so I'm going to, should I share the slide from my end?
No, it's been shared.
Okay, all right, thank you.
Yeah.
Okay, can I have the next slide?
Sorry about
Yeah,
that.
so, yes, oh, no. Can we go back to that slide? Yeah, thank you. Okay, so who we are, we were established by the Health Sector Reform Law of 2006. Before then, there was an agency called Private Health Registration Authority that was regulating mainly private hospitals, but the regulation was not effective and it was not being extended to the public sector. So a pharma was established to improve the quality of healthcare services and the operational efficiency of health facilities in the state. So our vision, as articulated, is to be a reputable regulatory agency that is effectively promoting quality healthcare for all Lagosians. And our mission statement is we want to ensure all Lagos residents have access to good quality and safe healthcare through effective regulation of health facilities, whilst monitoring their compliance with set standards. For us to effectively and efficiently carry out our duties, we had to articulate core values that all the staff would key into. And our core values are integrity, excellence, professionalism, accountability, client-oriented services, and teamwork. Next slide, please. Thank you. Okay, what do we do? Our functions as an agency is divided into 4 core themes. Setting minimum required standards, facility registration and licensing, research, monitoring and review, and governance and stewardship. Our activities is around monitoring and accreditation of health facilities, both public and private in the state. And of course, we process applications for registration of health facilities. We inspect the premises. We collate all necessary information on registered facilities. We have a database for all facilities that are registered with us. We disseminate information on indicators from time to time to the Ministry of Health, and we ensure compliance to the set standards. Next slide, please. Okay, so looking at the MNCH statistics for Nigeria and Lagos, it's obvious that the statistics in Lagos is much better than that of the national average, but we still have a lot to do in terms of ensuring that we improve the quality of health in maternal, newborn, and child health services. Next slide, please. Okay, so what are the challenges and barriers that result in poor MNCH indices in Lagos? As we all know that the Lagos has the highest number of health facilities in Nigeria, but even then, and we also have the highest number of healthcare workers, but even then, we still have an inadequate workforce, especially for doctors and nurses, particularly midwives, and it cuts across all levels of care. Then there is inadequate access to healthcare services, both in terms of financial and geographical barriers. The referral system is ineffective and inadequate. The quality of healthcare services overall is poor. And we all know that it's better for us to access good quality healthcare or no access at all, because accessing poor quality of healthcare leads to wastage. Then we have preponderance of traditional birth attendants at the community level and poor regulation and misuse of traditional and alternative medicine, which usually results in harm. Next slide. So what are the efforts of Lagos State government to address these challenges? The Lagos State government has a developmental agenda, which is called themes. And under these themes, there are certain innovations or initiatives that have been carried out. On the demand side, we have a dedicated budget line for financing of maternal and child health activities from the state health financing option. There has been an expansion of the state health insurance scheme, where the vulnerable and the poor population groups have been funded by government in an equity funding. There has been an increased community and public awareness on issues concerning maternal and child health care. And the state also holds a biannual maternal and newborn child health week, which is geared towards provision of essential packages. At this MNCH week, there are also incentives for the mother and child when they come to the primary health care centers. We also have outreach programs during this biannual MNCH week. Then on the supply side, we have establishment of comprehensive primary health care centers across all the senatorial districts of the state. We call these comprehensive health care centers flagship hospitals, and there are 57 of them. We have 37 LCDAs and 20 LGAs. And in each of these LGAs or LCDAs, we have comprehensive health care centers. And these comprehensive health care centers have, they have an improved workforce, where there is a minimum of 3 doctors, 3 nurses, and at least 5 community health workers to ensure adequate provision of health. Then there has been massive and aggressive capacity building of healthcare workers in the last few years, especially on maternal and newborn child health interventions. Then the state has instituted the MPDSR. It's the maternal perinatal death surveillance response in the state is very strong, and the agency, EFAMA, is a part of the steering committee. And at this MPDSR steering committee meetings, we discuss the issues and the barriers to the MNCH healthcare, and we also prefer solutions. Then one of the key things that has been done is also to strengthen and reorganize EFAMA, which is the agency that has an oversight on both private and public health facilities. And in 2015, an institutional capacity of the agency was carried out, and the scores were low, after which several activities and initiatives were done. For example, there was support from Global Fund, from Farm Access, and HSCL, Health Systems Consult Limited, and other partners in various ways. There was support to build the capacity of the staff. There was also support to improve registration by digitizing our registration. We now have a platform that's online. We now leverage on technology to carry out the registration process from beginning of the application right until the time for inspections. We have a digitized tool that we use also when go out on monitoring and inspections to health facilities. We have been able to articulate our processes, procedure manual with the help of Farm Access. We have been able to articulate our 5-year strategic plan with the help of HSCL, and we're working towards carrying out our activities or all our effectively so that we're able to perform on our mandate as articulated by the health sector reform law. Next slide, please. Okay, so I talked about the leveraging on technology, and that's the platform used for registration. Next slide, please. Okay, so what's the role of a farmer in regulating quality of MNCH service delivery in Lagos State? We have an obligation to monitor the performance of both public and private healthcare institutions. And we also ensure that services to women and children are of good quality. We carry this out by setting adequate standards that support management and treatment of MNCH services for the operations of public and private facilities in Lagos State. We formulate policies and guidelines to improve MNCH indices. For example, we have developed guidelines for the artificial reproductive technology practice. We know that there are a lot of charlatans in this space, and it became expedient to articulate guidelines for the practice in the state. Recently, we have also started discussions with our stakeholders so that we're able to articulate guidelines not only for ART, but also for telemedicine and cosmetic surgery. We ensure compliance of health facilities to MNCH policies and guidelines by accessing compliance to minimum standards for licensing. So we ensure that the infrastructure in the health facility is adequate, that they meet all built-in regulations. We ensure that the medical personnel in the facility, that they are adequate and they are appropriate, that they are qualified for whatever branch of medicine that they are practicing, and they are duly licensed by their professional bodies. We ensure that they have adequate medical equipment and supplies, and then that they have adequate protocols and standard operating procedures and guidelines for all administration of care. Next slide, please. Next slide, please. Thank you. So we also evaluate performance based on set standards. We carry out monitoring visits to the health facilities. I mentioned earlier that we leverage on technology. We're now using the health facility inspection tool, and we're also strengthening arrangements for monitoring by engaging franchisees, reputable private organizations. The monitoring staff in the agency is very small. The agency, our mandate is very large, but the number of people working in the agency is only about 35. So it's expedient that we franchise our monitoring activities so that we're able to meet our mandate of visiting each facility at least 2 times in a year for monitoring. We also attend to petitions on malpractices by health providers, and we ensure sanctioning of offenders. Sometimes the public will give the agency information. We're very open to whistleblowers, and sometimes we have petition of clients who have actually visited the health facilities, and they have had issues with these health facilities. We also work closely with the professional bodies on the sanctioning of offenders. We seal health facilities that are operated by quacks or unauthorized personnel, or when the facilities are not complying with our laid down regulations. And in this case, which the MNCH practices would apply. We have also deepened our engagement with stakeholders. We have increased our negotiations so that we enforce compliance. We are currently collaborating with professional associations and professional bodies. We're encouraging them to regulate themselves so that the job of regulation becomes easier. We're also encouraging the professional bodies to, do things right. Then encourage the professional bodies to regulate adequately so that the professionals themselves would be licensed, would have carried out all the requirements necessary before they are actually providing service in the healthcare facilities. We're also collaborating actively with the Traditional Medicine Board because we have a preponderance of traditional birth attendants in the state, and they need to be regulated effectively. We incentivize private facilities to build sustainable capacity for improving antenatal care, delivery, postnatal care, and strengthening health system functions that underpin quality of care. We do this by carrying out capacity building. We also carry out assessments for their empanelment into the Lagos State Health Scheme. We strengthen referral systems and quality assurance mechanisms. We encourage the private providers to limit their operations, to their capacity and to their competence, so that they refer readily, they do not mismanage patients, and we encourage linkage with public health facilities that are secondary health facilities. And we also encourage them to use our tool even before we come to visit them. Next slide, please. Okay, so in conclusion, effective regulation of health facilities providing MNCH services will ensure the provision of MNCH services that are safe, effective, timely, and efficient. And we believe that when this is happening, it will in turn improve the indices in Lagos State. Thank you very much for listening.
Thank you very much, Dr. Abiola, and also thank you for the previous presentation from Dr. Dada. So I think we've had two excellent presentations, and thank you for all the questions from participants on the call. So we will, we have taken note of all the questions now, and we'll be selecting a few of the questions and directing it to the presenters. So maybe I start with you, Dr. Dada. A lot of questions around mom care, and so the question is, how do facilities get to be part of mom care? Is it just hospitals? Is it maternity homes? And how do you make it affordable?
Okay, thank you very much, Nuhu. The way mom care is, it's actually a pilot. We're currently in 3 hospitals in Lagos State. And what we're trying to do is a proof of concept to see how well this would improve the quality of journeys in the 3 hospitals that we've selected. I think we don't work in maternity homes. And the reason for that is the Lagos State Health Scheme only engages hospitals managed by doctors. And that's because of the scope of basic and comprehensive emergency obstetric care services covered by the scheme.
Thank you very much.
Yes.
Okay, so we have a question which I think it was directed to you, but I'll also open to Dr. Abiola in case she wants to respond as well. And it's around insurance and paying for services. So they say on the question is on the insurance side, who are the payers? Does the state, is there cost sharing with the state? And how much does the state subsidize users in any way, if that happens in any way?
Sorry, I don't understand the
No,
question. Can you go by the way?
Health insurance service, paying for, so basically paying for services. And I think during Dr. Dada's presentation, she talked about the support in terms of helping to expand access to Lagos State insurance. So the question is, how are people entering into the scheme? Does the state subsidize payments, or is this the premiums fully paid just by the more pregnant mothers? Hello?
Okay, hello. Is the question to me or to Dr. Dada?
It's to Dr. Dada.
Okay, sorry, you referred it first to Dr. Edo. Okay, so for the scheme, it's government does pay subsidies. I know in the past, a portion of the Saving 1 Million Lives fund was used to fund premium subsidies for Makoko community, which is a slum in Lagos State. But the intention is, as much as possible, have people buy the insurance. So there are no co-payments really from government, except where they intend to pay subsidies. And I know for the Makoko community, which is a slum community in Lagos, it was 100% payment of premium subsidies for women identified as indigent.
Thank you very much. So Dr. Abiola, we have a question around collaboration and quality control. So the question is, how does HEFA MMA balance its regulatory enforcement approach with a quality control agenda based on partnership and collaboration?
So I spoke earlier that we collaborate with the professional associations and the professional bodies. One of the things we do is to ensure that we're supposed to authenticate healthcare providers. So the professional associations help us to identify people working in the community. So for example, the Association for Doctors would identify, like NME, National Nigerian Medical Association, would identify that this is a doctor. So we use that to at least authenticate the person. And then we also have meetings with them, sharing our standards so that they recognize that they need to comply with the set standards. And the reason why we're doing it is we want them to self-regulate. We used to come from the corner of enforcing the regulation, but we want to ease on that and encourage self-regulation. And we want a situation where at the end of the day, the healthcare providers would willingly carry out clinical audits by themselves and, ensure that they are providing quality service. I hope that has answered the question.
Yes, thank you. So in effect, we had a comment from someone saying, in effect, you're not just going and selling, it's a collaborative and there's a dialogue involved, not just that you go, that's all facilities are just sealed immediately. There is a discussion and collaboration that takes place before that.
Yes, in some instances, but there are some instances when the facility is not being run in the interest of the public and the community, and in the interest of the well-being of the patients. And in that case, we seal immediately. But those facilities that are run by professionals, usually we have dialogues and we give them time. We issue notice of compliance. We give them time to address the issues that they have.
Thank you very much. Maybe this I'll direct it to, yeah, I think this is to Dr. Dada. And it's around, I think, lots of questions on mom care. How do you ensure, including ICT? So the question is, do clients need to be connected to the internet to gain access to the mom care platform? And if yes, what's your experience in terms of percentage of women that have access among your beneficiaries?
So you don't have, women don't have to have smartphones to connect. It's really just having a phone number that we can send you SMS messaging, and you can also use USSD codes for. That's all. So you don't require, it's a simple feature phone that you require.
And maybe a follow-up question to you is then how, for the assessments, who is being assessed? Is it the mothers? Is it the providers? And how, in doing that, how do you give consideration if people access their services along the continuum of care? So they might also be taking into the fact that they had used other health facilities before coming to the mom care facility, and they also take that into the assessment. So how do you put all of that together?
Yes, so thank you very much. So one of the things is for every woman that joins mom care, there's actually an exit interview. So some of this information will be obtained during the exit interview. And even at the beginning, when she's onboarded, we take note of the time of registration. What gestational age was she at the time she registered? And where had she been accessing care before registering at the facility?
Great. So maybe link to that, Dr. Abiola. We have a question, and I think this is actually talking again about the public-private partnership. How does the government specifically build the capacity of healthcare workers on maternal and child health interventions? Are these being scaled, and how does farm access fit into this plan?
Okay, thank you very much. So we have training sessions for private health facilities. They actually, apart from the fact that we regulate, there's also a department in the Ministry of Health called Directorate of Family Health and Nutrition, and they usually have trainings on maternal, newborn, and child health for both public and private facilities. We also carry out capacity building for some private facilities. Then we, when necessary, and we also distribute like handbills. And then yes, definitely, I'm very sure Dr. Dada will be able to support the state in several trainings, both for public and private, on MNCH.
Dr. Dada, do you want to add anything?
Yes, so we are able to, we actually support the state with trainings. And what we also try to do is, of course, the state already has like a team of master trainers recognized by the Department of Family Health and Nutrition, and as well as the Lagos State Health Management Agency. So for the mom care facilities, the trainers will be drawn from the state master trainers.
Great, thank you very much. I guess this next question is two questions, but I'll put it into one. As I think these are from our colleagues from Nigeria who are participating. One is to you, Dr. Dada, is farm access also active in any other state in Nigeria? And for Dr. Abiola, the question is, what's your experience about if there are other agencies like HE, FA, MMA in other states in Nigeria? And maybe I'll add one to that. And how do you share your experiences of this great work you're doing with other states? So over to you. Maybe Dr. Dada will start first, and then Dr. Abiola will answer afterwards.
Okay, thank you very much, Nuhu. Yes, we do work in other states. I think we're currently in Kwara, and we're in other consortiums, the LAFIA Consortium and the IHP Consortium. LAFIA Consortium is in 5 states, and the IHP, that's the Integrated Health Program Consortium, is in 5 states also. So we're currently in about 13 states in Nigeria, working with other partners.
And Dr. Abiola, do you know if there are similar agencies like yours?
Yes, I'm aware that Oyo State, Kano State, and Ogun State, and I think Edo is trying to bring up something, and Ekiti. In 2019, the Ekiti State government, the Ministry of Health, Ekiti, came on a study tour to a farmer to learn from us how we carry out our operations. And in 2020, Farm Access supported a study tour from Kano State to see how we carry out our operations and how we leverage on technology to carry out our work effectively. Recently, we have shared information on how we carry out our operations to Ogun State, because I'm aware they want to put up something like a farmer.
Great, thank you very much. So maybe we'll have one more question for each presenter. So maybe with Dr. Dada, as at the end is we want to improve quality of care for mothers, newborn, and children. So the question is, has there been any improvement in quality of care in maternal and newborn health related to the use of mom care tool? So at facility level, have you seen that mothers through the use of this mom care tool, it has led to an improvement in quality of care?
Yes, it does. But for Nigeria, it's a relatively new project, but it's been implemented in Kenya for more than 2 years now, and Tanzania. And that's the reason why MSD for Mothers approved the rollout extension to Nigeria as the next country to implement mom care.
Great, thank you. And final question for you, Dr. Abiola. And I think this is to the whole question around governance and collaboration. How do you incentivize facilities to improve quality of care, and it's particularly the private health facilities? What are the incentive mechanisms you have for them?
Okay, recently, I'll start from the most recent. So recently we just started what we call ranking or recognition of private health facilities that have done well, and then we celebrate them. That is one. And then we also carry out capacity building for these private health facilities. For example, Farm Access supported some webinars last year for private health facilities. And then we carry out assessments for the Lagos State Health Insurance Scheme, and you have to have some level of quality before you can join the scheme. So, and I think joining the Lagos, it's an incentive, like a market force. At the end of the day, it is only those who can continue to improve their quality of care that can access the Lagos State Health Insurance Scheme and stay on it. So that's an incentive as well. Thank you.
Thank you very much. Thank you very much, Dr. Ido. And I just want to
No, you are muted.
Oh, sorry, I was muted. So I just want to thank Dr. Ibironke Dada and Dr. Abiola Idowu for making this excellent presentation, sharing their experiences, and also for the very perceptive responses to all the questions. I also want to thank all the participants. We had a huge group today, so thank you everyone for the discussions. We really appreciate it. And I also want to thank our partners, WHO, MSD for Mothers, and also the Child Health Task Force Group. So please stay engaged. As I said at the start, this is a series, and we will continue having this sort of webinars where we're going to share experiences around private sector engagement for quality of care services. Please do join the community of practice where we'll be uploading the presentations, the recordings, and also both Dr. Dada and Dr. Abiola will be there to respond to some of the questions we haven't been able to get to, and also to carry on the conversation. So please do, you can find the network for the quality of care for improving the quality of care for mother, newborn children on Twitter. So please join the conversation. The hashtag is #quality of care. All presentations will be shared after this. So thank you, everyone. Have a lovely day and happy Easter to those who celebrate. Thank you very much.
Thank you.
Thank you. Bye.